Hi, my name is Ken Nischal. I'm Chief of Pediatric Ophthalmology and Strabismus at Children's Hospital of Pittsburgh, and I'm part of the Center for Rare Disease Therapy. I'm glad you could join me. We're going to talk today about congenital corneal opacities, the classification and the management. Now, there may be some time at the end of the talk for some questions, so if you have some questions, do send them in and I'll try and address them. But I think the important thing is really to try and cover this subject with as much depth and breadth as possible. So these are my disclosures, none of which actually pertain to the talk itself. So I always like to start off with this picture. This is a picture of a rock in a place called Petra in Jordan. And when you look at this rock, can you see that it looks like an elephant? There's the trunk, the eye, and the ear. When you look at this rock, if you were standing over here, some people see this as a fish. There's the eye, the mouth. Some people see it as a skull. There's the jawbone, there's the socket of the eye. And my point of showing this picture is that the condition of congenital corneal opacity has been viewed in different ways over the years by different people and different doctors, such that there's a little bit of confusion now about the classification. And so if you can look at one piece of rock and two people can see two different things, it's possible sometimes for the same thing to happen when you're looking at an eye. And so I'm going to try and show you features that might help explain why this happens, but also explain how we can move forward and improve our treatment for children born with corneal opacities. So the first thing I want to do is that this mnemonic STUMPed has been used for many, many years to teach medical students and ophthalmology residents about the different causes of corneal opacity at birth. And I've put a big red cross through it because it's not helpful. It's not helpful because it doesn't allow the doctor or the patient, I should say the parent of the patient, to understand what might be going on. So I know the talk is supposed to be entitled Peters Anomaly and Sclerocornea, but Peters Anomaly actually is a bad term. Many years ago, actually 17 years ago now, I was involved in a study where we looked at children who were born with corneal opacities, and we made a clinical diagnosis of what we thought was going on. In 40% of those cases, the diagnosis actually changed once we'd done a high-frequency ultrasound. And a high-frequency ultrasound is a special imaging technique which allows you to look into the eye without opening the eye. So in this particular study, here's an example. This is a corneal opacity in a newborn child, and this was described as being sclerocornea. And the reason why it was described as being sclerocornea is because the edge of the eye, where the colored part of the eye normally meets the white of the eye, is sort of more anterior and there's a diffuse opacity. But actually, when we did the high-frequency ultrasound, what you see here is the lens attached to the cornea. This is called keratocornea lenticular lens adhesion. This is what you're supposed to see in what people call Peters anomaly type 2. So I think you can immediately see that the clinical diagnosis of sclerocornea was actually incorrect. So imagine if 2 out of 5 times, that 40% of every time you see a corneal opacity, you're actually going to make a misdiagnosis unless you have some sort of imaging. Based on my experience since 1998, I wrote this paper and I called it a new approach to the classification of neonatal corneal opacities. Have a look at these pictures. Each and every one of the children in these examples was referred to me with sclerocornea. And I guess that's why I want to stop for a minute and say sclerocornea and Peters anomaly are not diagnoses. They're signs. A bit like having a cough, you know. You've got a cough. That doesn't mean it's a diagnosis. The diagnosis of why you've got the cough may be a cold, an irritation, an allergy, or something more severe like a lung cancer. But the cough itself is not the diagnosis. So similarly, if you call all of these sclerocornea, you could call it a sign, and the sign is that you've got total corneal opacity. It's not a diagnosis. So let's have a look at this classification that I've told you about. Now, I know that there are people listening who are not necessarily medical, but I'm going to try and help everybody understand this a little bit. Don't worry about the details. What I want you to do is look at the left side of the screen where it says primary corneal disease. What that means is that the abnormality is only in the cornea. The rest of the eye is completely healthy. If you have conditions like that, then doing a corneal transplant actually is a good idea, and they do very well. We then look at secondary corneal disease, and here we talk about developmental anomalies of the anterior segment. Sometimes we call this anterior segment dysgenesis. And there are a number that I'm going to go through with you and talk to you about, but you can see that the only one here in green is what we call iridocorneal adhesion. That means when the iris, the colored part of the eye, is stuck to the cornea. And what we know is that the prognosis for surgery, for corneal transplant surgery, is relatively good in these situations. But you'll see that in this group, there are some red ones as well, and they do poorly. So I think you can see that if you can make the distinction between a group that's going to do well versus a group that's going to do poorly, that's helpful to the physician and helpful to the parents to help decide what to do. Now, many places where I talk around the world, doctors will tell me, we don't have a UBM or we don't have high frequency ultrasound. Doesn't matter. In every hospital that has anesthesia, there will be an ultrasound machine that is used to identify blood vessels when you're trying to find a vein to put a cannula in. That ultrasound is the one you're seeing here on the top left. And you'll see that it allows you enough detail to see the lens and to see that there is something going on here where the lens appears to be attached to the cornea. Now, on the top right is the high frequency ultrasound picture, and clearly it's more detailed, but you can see that the image on the left does actually give you a diagnosis, and it explains why this corneal opacity is present, because the lens failed to separate from the cornea. So this is Hannah Skanger, who is one of our genetic counselors, demonstrating the difference between the ordinary ultrasound used by ophthalmologists, that's the one on the bottom left, with the probe that's flat, and this, what we call linear ultrasound, that gives you the much better image of the front of the eye. And almost every department I've been to in the world will have in their anesthesia department one of these ultrasounds, because it helps them find blood vessels when they're trying to cannulate. So for the doctors out there, if you don't have a UBM, it doesn't matter. Try and speak to your anesthesiology team to see if they have one of these machines that I'm demonstrating to you here. So again, the clear distinction in the same eye, the difference between the regular ocular ultrasound and the linear ultrasound, giving you so much more detail of the front of the eye. And that's how it's done. It's done through the closed lid. And often I will do an ultrasound on babies awake. You don't have to put them to sleep to be able to get the information that you need. Okay, back to the classification. Let's go through some pictures to show you what these different entities look like and how we deal with them. So one of the most common corneal dystrophies, and a corneal dystrophy is a genetic condition that predisposes the cornea, the window of the eye, to be cloudy. In this one, congenital hereditary endothelial dystrophy, we now, instead of having to do a full thickness corneal transplant, can just remove the inner layer that's diseased and replace it with an inner layer. This is an older child, and this was done 20 years ago when I did a full thickness corneal transplant. But more recently, and this is just the histology showing the abnormality, but more recently, what we're able to do is just replace the inner layer, and this is a special imaging technique that shows that just the inner layer has been replaced. You see this thin inner layer? It's a much safer operation. You're not compromising the integrity of the eyeball, and that's what the eye looks like, nice and clear, having been cloudy. So making the right diagnosis is important, right? If you diagnose CHED, then we know that there is a good operation that can give you a good outcome. Let's look at some other ones. This is a child who has a corneal dermoid. Now, the dermoid is extensive, and when the child came to me at the age of 9, no surgery had ever been offered, and unfortunately, incorrectly, a diagnosis of Peters anomaly was made. You'll see when I show you cases of what people have called Peters anomaly that this clearly isn't that. This is a corneal dermoid. And the great thing about corneal dermoids, here's another one, is that we can remove them. Now, if you are in an area of the world where there isn't the expertise to remove them, in this particular case, you could also just do an optical iridectomy. That's to cut the iris out in this one quadrant to create a new pupil. And I'll show you a picture of how that's done in a few moments. So the treatment options are lamellar keratoplasty, removal with SLET. Now, don't worry about that. This is a new technique that we're just publishing, but I will show you it so you're aware that what's available. And optical iridectomy. Ideally, if the dermoid is laterally placed or superior, because if you do an optical iridectomy in the upper half of the eye, the lid is going to cover it. So it's not going to be that helpful. Excuse me. Okay, so here is a child that was sent to me with a big corneal dermoid, and the special imaging technique I'm showing you allows us to see the depth of the dermoid. As long as the dermoid doesn't penetrate into the eye, you can shave it off and either replace the tissue with other donor corneal tissue, or if that's not available, see, this has all been shaved off now, you can actually use a technique called SLET. This is just showing us the depth of the dermoid that was there and what's left after removal. And this is showing the SLET technique that we're doing in this particular child. And what you see over 2 or 3 months is a nice healed cornea, and the dermoid is completely gone. And this is just showing that the area where the dermoid was removed has sort of partially filled nicely with the SLET that we did. Okay. One of the reasons why making the right diagnosis is so important is demonstrated by this case. This is a child who was born with this cloudiness in the eye, and it's in both eyes. For the doctors in the audience, this particular appearance I like to call a reticular flat dermoid, and it is pathognomonic of one condition, and that condition is trisomy 8 mosaicism. And it's extremely important that that's recognized, because the child then needs to be evaluated from the cardiac and renal point of view, so the heart and kidneys. So again, I have a child coming to see me in whom this particular opacity was claimed to be Peters anomaly. Just because you have a corneal opacity at birth does not mean you have Peters anomaly. Okay, this is a condition called isolated sclerocornea. It's not a good name. It's a better name is cornea plana. And what happens here is the cornea is very flat. So these children don't need corneal transplant or anything. They just are very, very long-sighted, and they actually need a good contact lens fit to help them see. But again, the term sclerocornea being misused in a different capacity. So let's move on to secondary corneal disease. So now what I'm saying is that the corneal disease that you see in this picture is directly due to the iris touching the cornea. And these lovely pictures here on the right are from Leslie McKean, who used to be at Toronto Hospital for Sick Children. Can you see here that the opacity has no blood vessels in it? That's a really good sign that you're dealing with pure iridocorneal adhesion. Why is that important? Because Jerry Zaidman, who's a very good friend of mine and an excellent corneal surgeon, showed in a very nice paper in 2007 that the visual outcomes in these children with iridocorneal adhesion, used to be called, or some people still call Peters anomaly type 1, is actually good. Now, the timing of surgery is something we'll talk about in a minute, but you do need, however, even when the outcome can be good, to have somebody who understands the difference in operating in children under the age of 1 and adults, and that's really very important. So what are your treatment options? You know, penetrating keratoplasty, of course, is a treatment option, but so is optical iridectomy, and the social circumstances and the number of siblings that the child already has affects that decision making. Let me explain why. If you have a child who's the first child of a couple, the chances are that they will be able to devote the time and attention needed if a corneal transplant is done. If, however, this child is the 8th child of a couple, then there is going to be a certain amount of difficulty in providing the same amount of attention. Now, I'm not saying that that is always a deciding factor, but it is a factor that I discuss with the parents and say, look, you know, if an optical iridectomy is an option, that is an option that we should consider based on the following reasons. And I think that that's really important, because when you do a corneal transplant, the follow-up is crucial. Being vigilant about what's going on with the graft is crucial to its success. So let's have a look at this case here. You can see that there is an opacity, but there is a nice amount of clear cornea. The iris is stuck underneath that opacity. So what I've done is I've twisted the eye around so that the inferior part of the eye is now accessible. I've made a cut. I hope nobody's having their lunch. I've made a cut in the cornea. I pull out the iris, I cut the iris, and I sew up. It's a quick, easy, safe option. And when you have this much clear cornea, it really is a good option, especially if it's the same in both cases. Here's a lovely boy that I dealt with many, many, many years ago, who came to me from Uganda, and he'd been sent to me for the possibility of a corneal transplant in both eyes, but it became clear that there wasn't going to be anybody, sorry, I'm just switching off my phone, there wasn't going to be anybody where he, in the remote part of Uganda where he was, who would be able to monitor this child's corneas. So rather than do a transplant and have it fail under those circumstances, we decided to do bilateral optical iridectomies, and I'm really pleased to tell you that he goes to school and is doing really well. So what if the opacity is so big that you cannot reasonably do an iridectomy? Here is one such case. And here, the opacity is pretty large, and you only have about 1 millimeter worth of clear cornea. And what I'm showing you here briefly is the difference between operating in infants and operating in adults. In infants, the wall of the eye is so elastic that I hope you can imagine for a minute that as you take the diseased cornea off, you're opening the eye. If the wall is very elastic, like an elastic balloon, it's going to want to collapse at that moment. And if it collapses, then unfortunately, you can have a very severe hemorrhage that can cause loss of the eye or severe damage to the vision. So what we do here is we tie a ring, it's called a Floringer ring, to the wall of the eye, and we leave one end of each suture long. By doing so, what we do is we use the long end of the suture and we stick it with a special sticky sterile tape to the cheek and the brow. And you can see now how the eyeball is being held up. What I've just done there is made some marks so that I know where to put my sutures. And now what I'm doing is I'm going to inflate the eye with a special viscoelastic, so I'm protecting the lens as I do my trephination. Trephination is the cut that you make in the host tissue. So I do a partial trephination and then I finish off the rest with scissors. Okay, let me show you some cases then that have been done. And what I want you to notice is the majority of them actually have no vessels. So here is the child, and this is showing that the iris is stuck, but not the lens. Similarly here, here is the iris, though you have got one blood vessel here. This case was sent to me as a Peters anomaly, and in fact, it's not a Peters anomaly. There's a cyst inside the eye. So the treatment here is to remove the cyst, not to do anything to the cornea. But in these other cases, the options were either corneal transplant, and here you can see that there's not enough clear cornea to do anything else, whereas here there was an option, but it was in this particular case, and this is important to remember, if you do an optical iridectomy when the disease is only in one eye, the outcomes are not as good as if you were to do a corneal transplant. Now, doing a corneal transplant when the better eye is completely normal is also a potential problem, because that eye is never going to see as well as the good eye. However, if the better eye has a problem, for example, an early cataract, or has a partial opacity that's not completely obscuring the visual axis, then I would do a transplant in the other more affected eye, because you never know when the better eye may run into problems. Okay, so here are some cases, right and left eyes, before and after. In this particular case, I think this is about a year and 2 months post, maybe even more, 2 years post the initial transplant. When you have bilateral disease, that means that both eyes are affected. I have learned that it's better to wait till the child is around 4 months of age, so 3 to 4 months, before I do the transplant. And the reason is that the rate of complications in my hands has reduced significantly when I've done the surgery when the child is after 2 months of age. And this is something I have to thank Jerry Zaidman for sharing with me, and I would agree with him. One of the things that people argue about is that the longer you wait, the less the chance of vision. While that's strictly true, practically, if you have multiple complications, you're affecting the visual development of that child. So it's better to say, okay, I know the vision is going to be a little less good, but if I can get less complications, less having to take the child back to the OR, then that's much better for the child overall in terms of visual development. So here's another, I think this is another child, I think maybe the same child, but at different stages, just showing the healing of the graft on the host. Okay, we've talked about corneal transplants, and I've talked about the fact that if you have type 1 Peters anomaly, don't like using that term, but I'm going to, type 1 Peters anomaly, which is the iridocorneal adhesions, they tend to do well. But what about the ones who don't do so well, and what do we do about those? Here is a child who has an opaque cornea, and the imaging shows that the lens is stuck to the cornea. It failed to separate. Here's another child. The clue here is that there are lots of blood vessels everywhere. And when I removed this cornea, I was very surprised to find that the lens had never separated from the cornea during development. I hope you can see that it's really quite, I'll go back, it's quite a fallacy to say that this condition where, or this one, where the lens never separated, is the same kind of animal as this condition where only the iris was attached. The prognosis when only the iris is attached is much better than when the lens is attached, because there is a fundamental abnormality in the development of the eye. And it's not a surprise that in the development of the eye, if one part of the eye doesn't develop properly, it has a knock-on effect on other parts of the eye. And that's why these cases tend to do less well. If you have to remove the lens, or if the lens is not present or is partially degenerated when you do a corneal transplant, the survival rates of that transplant drop dramatically. So if you have a unilateral case, a case where only one eye is affected, and you've got the lens attached or not present or degenerated, you are going to get a poor outcome if you operate. If, however, both eyes are affected, then in my opinion, you should try and get some vision out of that eye, and I'll show you what I mean a little bit later on in the talk by actually demonstrating what success means and what success is when you're dealing with congenital corneal opacity and treatment. So here is a child where the lens is attached. The iris is attached as well, but the lens is attached, causing secondary changes in the cornea. I know, and I've said to you, that if we operate on this child and do a corneal transplant, the chances are that that transplant will fail. There's a higher risk. But what is glorious about this child, and in terms of having some good luck for all the bad luck that the child may have had with having the opacity, is that the child has got a good amount of clarity of the cornea. So what you can do is you can do a lovely optical iridectomy. So this is inferior and towards the nose. And now you've given this child a lovely window of light, which the child can see through. Now, it's incredibly important that when this is done, after 6 to 8 weeks, that the child have another exam under anesthesia or sedation to get an accurate refraction or reading for glasses. This is really crucial. Doing an optical iridectomy and not getting an accurate pair of glasses afterwards is you may as well not have done it, because you're going to give the child maximum visual rehabilitation, and that is what we're trying to do. So the ones in red, the lens fails to separate from the cornea. If you can do an optical iridectomy, you should do one, because the chances of success are lower. But sometimes you have no option. There isn't enough clear cornea to do it. And I'm going to show you that even then, it's still worth doing, and I'll show you why. Sometimes the lens separates and then fails to form, the degenerated lens. It's the same problem. If the lens degenerated, there's something inside that eye is not normal. When you do the graft, the chances of success are going to be lower. But in this child who's affected in both eyes, doing nothing means that you condemn this child to practically no vision. However, if you are going to tackle a case like this, you tackle the child's eye that is the worst eye. In other words, if the child sees well with this eye on the left, you only do the transplant on the left eye. You always operate on the worst seeing eye so that you never compromise the overall function of the child's vision with both eyes open. That's really important. If you do the worst eye and then it becomes the better seeing eye, then you can consider doing the other eye, because it's no longer the better seeing eye. There is this one condition that's very rare, but we see, for some reason, we see a lot of it here at the Center for Rare Disease Therapy in the Department of Ophthalmology. This is the silver-looking cornea. And in here, and in this case, the lens never formed. Now, these are difficult cases because if you do a corneal transplant, because the lens never formed, they are at risk of failing. And failing because the jelly inside the eye, the vitreous, is abnormal, and it tends to cause the eye to shrink. The problem, however, is that if you do nothing, they tend to get glaucoma and can get spontaneous perforations as they get older. So here's another child with the condition. The cornea is so thin that you can transmit light through it, but when sunlight or ambient light hits it, it looks opaque. It's due to a mutation in FRCOphth, which is a lens gene. And so it's important here, right, to understand that calling this sclerocornea is not appropriate. It's got nothing to do with the cornea. The cornea is a secondary effect of the fact that the child didn't have a lens. At this moment in time, we don't know how to fix that. So when we do, and we have a big research program here with Baresh Chauhan, who leads that for me, my molecular biologist, we'll be able to give adjunct therapy to the corneal transplantation as well, but we're a little way away from that. Right, for some reason, there we go. So you don't do a corneal transplant, but you control the glaucoma with a tube. And if you do that, then these children will have some vision. It won't be normal vision, but you won't have risked the eye. Now, recently, I have been, in a couple of children, been doing a corneal transplant in primary aphakia. And while they have been successful in the sense that the eyes have not gone soft, the vision, I would say, is probably about the same as if we had done nothing. We haven't lost anything, but we haven't really gained anything. So at this moment in time, I'm reluctant to pursue corneal transplant, though the two that we have done recently, the eyes have not gone soft or been lost, which is, of course, good news. So I want to now go on to complications. when you do a corneal transplant in children, it's not like doing a corneal transplant in adults. In a child who's under the age of 1, the sutures can become loose. And if you don't act on a loose suture, you can get a total rejection within 24 hours. You can get glaucoma. Glaucoma is when the pressure of the eye goes up. And if you are not aware of that, your transplant will fail. So you have to be prepared to manage the glaucoma, sometimes with laser, sometimes with a tube. They can also develop a cataract. And when you remove the cataract, never think of putting an implant in, because the front of these children's eyes are crowded already. And if you try to put an implant in, the anatomy is abnormal and you will damage not only the graft, but also other structures in the eye. So remove the lens and then use glasses or contact lenses. Okay. Early suture removal. This is a baby who had all the sutures removed at 6 weeks, and it's a nice clear cornea. This is a child who got loose sutures. Unfortunately, the parents couldn't get back to me soon enough, and the local doctor didn't recognize, understandably, because he or she was not an expert in infant corneal transplants, that the sutures had to come out quickly. And the child started to get a rejection. What I'm going to show you next is really quite upsetting. This is a child who I did many, many years ago in England, and he lived in a part of the country that was quite remote. And the local ophthalmologist felt that he could do the follow-up, and it was perfectly understandable that he might, and I thought he would too. But a loose suture was missed. And by the time the child got back to me, the whole graft had rejected. So when children come to Children's Hospital of Pittsburgh and do not live in the area, I ask that the parents stay at Children's, normally in our Ronald McDonald House, for a minimum of 8 weeks. So that the surgery is done, they're seen twice a week for 6 weeks, the sutures are removed at 6 weeks, and then after 2 weeks they can leave. Sometimes at 6 weeks, the wounds are not appropriately healed, so you have to keep them a little bit longer, which many of them don't like, and so I'm not terribly popular when I have to make that decision. But my main concern is the child and the outcome of the procedure. Okay. Often when you do the operation as well, you would have seen that I sort of make a little cut in the skin of the eye, and you see there's more cornea than there appeared to be. Well, when you do that, you get this sort of graying of the periphery of the cornea. It's not a rejection. It's because of this procedure that was done, so that you had enough of a large graft to be able to get a good result. Glaucoma is a problem. Here's a child who's had a graft and has had a tube placed. This is a patch graft. I don't use sclera anymore. I use clear cornea, so it doesn't look so obvious. So let's now talk about a particular type of condition. This child was told, the mother was told, has Peters anomaly. And actually, when I looked at the child, I wasn't terribly convinced. And the reason why I wasn't convinced is that although it is a white opacity in the middle of the cornea, the front of the eye, what we call the anterior chamber, was flat. And if you look here, unlike the other pictures I showed you, there's no disruption of the cornea. The lens is touching the cornea, but it's touching it as an acquired effect, not as a congenital embryological defect. And what was happening, and this is a paper that I wrote about this, is that basically the lens was touching the cornea because of a developmental anomaly in the lens. And by removing the lens through this technique that we've published, you can see that the lens was still touching a little bit, but I've removed the lens, sucked it out, and this is showing that there was a plaque behind the lens that was pushing the lens forward. And by getting rid of all of that, you can see that this is what at the end of the operation the eye looked like. And then at 6 months, the child's got a nice window. There's a little bit of haze there, but we've got a nice window. We've not had to do a corneal transplant, so there's no rejection, and we're rehabilitating this child with a contact lens. So my point again is that if you make the accurate diagnosis, you get to make the best management decision. Calling everything, every eye that has an opacity at birth that is central, Peters anomaly, is incorrect, unhelpful, and misleading. So that's really, really important to get a deep phenotype. Again, I'm showing you this classification again. I'm not really going to talk about the things on the right because they don't really affect infants. They come on later in life. But remember, the things in 3 do relatively well. In green do relatively well. The things in red do poorly. Here's a child with aniridia, and you can see that the lens is attached, and you've got this opacity. The thing not to do is a corneal transplant. The thing to do here in this child is to remove the lens and give the child a clarity. Here's a similar child with a connection of the lens to the cornea. Here, I've taken the lens out and I've cut the pupil open more so the child can see with a contact lens. You do not have to do a corneal transplant in every child that has a congenital corneal opacity. Our aim should be to give them good functional vision so that they can develop normally, and then if we get bonus of good central visual acuity, that's fantastic. That is amazing. And that happens, but that's not our goal. Our goal is to get children to develop normally as a whole. The global development of the child is affected dramatically by improving the vision only slightly. Okay, so what is success? And I'm coming to the last part of my talk. The child that you see on the left had several corneal transplants. I had one corneal transplant with several episodes of graft failure, but would wear a contact lens. The mother was very good at patching the other eye, which was much better and almost normal. And the child got 621 vision, which is the equivalent of 20/70 vision with a contact lens. This eye, this child, the corneal graft looks lovely, doesn't it? But the child would never patch. Mother could never get the contact lens on. Child wouldn't wear the glasses. And the child has 6/180 vision, which is 2600 vision with glasses on. So I ask you, what is success? In the adult world, the one on your right is a success because it's a clear cornea. To me, the one on the left is a success. Even though it's not a clear cornea, the child has a small optical window here that's clear, and it's using that vision to develop and to see. So we talked about the cases where both eyes were severely affected, and here is one such case. This is a child, the eye, her left eye, which is the one I'm pointing to now on the right, was the better looking eye. You could at least make out where the cornea might be. This eye was completely opaque. And I did a corneal transplant and she started to reject. And then I did another one very quickly. And after about now, 9 years, this is the window in that eye. This child walks unaided in unfamiliar surroundings. In a playground, nobody could tell that she has any problems. But of course, her central vision is not as good as another child her age who has no problems. But she functions. She's normal in terms of development. This child, and by the way, the parents of both children have given me permission to show you these videos. You'll hear the mother getting more and more distraught as her son starts to climb the ropes. He had bilateral corneal opacities at birth and had surgery this was about 15 years ago, I would imagine, 6 weeks and 8 weeks, when I was still doing it early. And you'll see this child climb this ladder, or a rope ladder. That's his sister up there. I guess she's there just in case. And he wants to go down the slide. So he's going to make his way across. He's going to climb onto that slide. And he's done it. So the question that I ask audiences around the world when I show them this video is, what is this child's central visual acuity? And what I mean by that is, if you used to sit him in front of a chart, what letter would he read? Now, in America, the top letter on the chart is 2200. In Europe and other parts of the world, it's 660. This child's central visual acuity is 22,000. That's the equivalent for an adult of counting fingers at 2 meters. And I think this is one of the most salient points that I need to make, both to the physicians, surgeons, and especially the families of patients affected with congenital corneal opacity. When an infant is given a little bit of vision, the brain of that infant uses that vision for maximum visual function. Central visual acuity is only one component of visual function. Spatiotemporal relationship understanding, contrast sensitivity, color vision, movement, all of these play a part in visual function. And what seems to happen at these children, because they've been affected from a young age, use their visual function much better than an adult who might suddenly lose their vision to the level of 22,000. So I spend a great deal of time traveling the world talking about these children, these conditions, and the management for these conditions. And at the end, I'm always reminded that, not only reminded, but also have to remind people that when you deal with a child, that child is a developing neurobiological system that continues to learn, adapt until the age of around 8, when the plasticity of the brain sets. If you give that system a little bit of vision, even just a little bit of vision, it will use it dramatically compared to adults. Of course, I would love the cornea to always be clear, and it is sometimes, and sometimes it's not. That's after graft. But doing an optical iridectomy is a good option, especially if it's bilateral, because the child uses both eyes and gets good, not only good visual function, but reasonably good central visual acuity. So here's my take-home message. Deep phenotype. Peters anomaly and sclerocornea are no longer appropriate terms, in my opinion, in 2019. It's much better to talk about primary corneal disease and secondary corneal disease, so we understand what the problems are facing us and what the prognosis is. And we need to redefine success. Success in terms of developmental vision is much more important than corneal clarity. Corneal clarity is important, but not in sacrifice for developmental vision. So I hope you've enjoyed that webinar. For the physicians among you, the World Congress of Pediatric Ophthalmology and Strabismus is being held in Amsterdam in 2020, and I hope to see as many of you there as possible. So I know there are some questions. I'm going to, can I pull that down? Okay, so it said, I'm going to read you the question. It says, if a child has only one eye, and that eye is microphthalmic and has total CCO due to congenital aphakia, what will be the approach? I think I've already said that in congenital aphakia, if there's only one eye, I really would not touch the eye at the moment. There is a tremendous amount of research going. I just came away from a research meeting with Baresh Chauhan and my team, and we're not the only ones in the world. There are many teams. We're looking for solutions. So I would hang in there, because if you lose the eye from an operation, there's nothing to hold on to. It says, my son, next question, my son had an iridectomy at 6 weeks old. We had an appointment at 9 weeks old. Our next appointment will be when the baby turns 6 years old and no glasses are prescribed. You know, it's difficult to know exactly you know, what the circumstances are, and I really don't want to get into particular you know, the details of each case. This is what I would say in general. In general, it's important, as I said in my talk, at around 6 to 8 weeks after the iridectomy, to get an accurate refraction. That's difficult to do with the child awake. So I often will put the child to sleep under a brief anesthetic to do so, and that's the way I handle those cases. I don't see any other. Oh, here we go. It says, as I said, there were no questions. They've just come up. Can iridectomy help congenital aphakia? No. In congenital aphakia, there is no iris. If you have no lens ever form, the iris never forms, the cornea never forms properly, and the jelly in the eye never forms. And to do an iridectomy, you have to have some clear cornea. And in congenital aphakia, as I showed you, the cornea is always silver, or it can be very small and silver, and there is no clarity in the cornea to be able to do an iridectomy. Yeah, this is a great question. Some people say, okay, I've just missed. Let me come back to this question in a minute. It says some people say that plasticity of the brain may be lifelong. Do you agree? I agree that if you have opacity in both eyes, whether it's in the lens, cataracts, or whether it's cornea, what we're talking about, the plasticity of the critical period, that's the first 3 months of life, in my opinion, gets extended. I think that the quality of vision, the older you are, so if, you know, waiting till a child's 1 and they have bilateral severe affected corneas, I think the benefit risk ratio now goes against waiting. Question, what aspect of the child's care is most important to ensure optimal success? A good relationship between the doctor and the parents, a good understanding of the parents as to what reasonable expectations are, and number 3, to follow the doctor's instructions in order to get the best result. The last thing is, parents are the child's best carer, not the doctor. I'm only an advisor. I'm a technician. And the best outcomes for the children that I've looked after have been in those families where the parents have been totally and utterly vigilant, you know, and picked up an early infection. Infections can happen in corneal transplants as well. And they pick them up early, they contact me, and we start treatment early so we can salvage the cornea and still give the child vision. So I think those are the main parameters. Then what? Oh yeah. So it says I don't think I've missed anything right. This is the latest question. My son, it says, has asymmetrical bilateral opacity, but the most affected eye is the left one, which also has microphthalmia. Is it possible to operate like well, again, if you have microphthalmia, the area of your cornea is smaller, right? Now, if the area is smaller, then you have less of a window to get an effective window of light into the eye. So, again, difficult to discuss details, but in general, you need a clear cornea to be able to do an iridectomy and a reasonably normal-sized eye. So my next question is, my 20-month-old baby has complete corneal opacity and microphthalmia. Unfortunately, we haven't got the chance to treat it yet. Electrodiagnostics show vision prospect in the back of the eye looks normal according to the doctor. We're getting ready for treatment now. Please, what are the options and chances for success? I really, really wish that I could advise you, but without seeing pictures and having an appropriate examination, I really can't advise you. And you should, it sounds like the doctors that you have done everything we would do. We would do electrodiagnostics, and I think that you should follow their instructions and their advice. The last question, which I'm going to take because it's sort of coming to the end of the hour, is what is the age of the donor of the cornea, or is it not important? You know, I just for a minute, I want everybody to just think about this, that humanity is an amazing thing, that a parent can lose their child unexpectedly and yet still agree and think about the benefit of another child. And it is no doubt in my mind that the best cornea, donor cornea tissue is above the age of 4 and below the age of 30 or 31. And I want to just for a minute, I want everybody to think about what that means is if you lose a child unexpectedly, to agree to donate the eyes for the benefit for another child. I think that just, I think it's an amazing reflection of the goodness in mankind. Unfortunately, we can't always get material that age, but the second criteria, and perhaps just as important, is the number of cells on the inner layer of that cornea. They're called endothelial cells. And if you have close to 3,000 per millimeter square or more than 3,000, then I have taken material from patients as old as 41 or 42, but they've had corneal endothelial cells that have been, you know, very high. So with that question, with that last question, I want to thank everybody for listening. I actually want to dedicate this webinar to one of our patients who unfortunately passed away. Her name is Louisa Omachir, and we're all thinking about her family. And I want you to remember this, that even though your child may have eyes that are not working properly, you have a child. So give them a big hug and think about that when you're getting very, very worried about their eyesight, which is, of course, appropriate to be worried about. But remember to give your child a hug. Thank you very much indeed.